this is a sad story here, but this is another patient who has felt well. My sister lives 1,000 miles from me and is very sick.
Oh.
All right. She had a rapid weight loss of 70 pounds. Well, we know something's not right. And a pain in her abdomen. Well, now this is going to be a different pain in the abdomen than the woman in the first question had. She saw several in-the-box doctors over about 3 months as she lost weight and was given drugs for GERD, protein supplements, and she was not anemic. So she went into urgent care centers that she did not have a relationship with a primary care doc. Each one of them sees a static moment in time, right?
Mm-hmm. Yes.
They don't see her from the month before where she's lost 18 pounds. They see a patient complaining of heartburn, so they give them GERD medicine or some other sort of treatments. And then at some point she was talking about losing weight. She wasn't anemic, so they told her to take a protein supplement. But nobody has taken a chance to spend some time because she's not in the place. She's not in the place where somebody's mindset is in taking care of a human being and coming to an established diagnosis. I don't think much more lab was done until she demanded a CAT scan. Now, people have good intuition sometimes, right? I think something's wrong. She demanded a CAT scan. She had a liver full of cancer, and a biopsy said poorly differentiated high-grade neuroendocrine cancer. Now, I know that the answer, this lady who lives 1,000 miles away, next consulted Dr. Google. She went and looked up poorly differentiated high-grade neuroendocrine tumor because I can tell from the rest of the question that she's questioning a little bit what the doctor said that's 1,000 miles away. He said he was sending the tumor out for genetic testing. Now, we do that every time we talk here, don't we? You
Yes.
got to have genetic profiling. We need to know that to be able to get directed, remember, targeted therapy or immune therapies.
Right.
Keytruda for everybody, directed therapy. So he did exactly the right thing. But that she was so sick and going downhill so fast that he wanted to start a 3-drug chemo regimen like the lung cancer regimen. So I know that she has been on Dr. Google, and I know what he's talking about here is treating her like she has small cell lung cancer, because that is a poorly differentiated neuroendocrine tumor. When you do a Google on neuroendocrine tumors, which I know she did, it says that neuroendocrine tumors are primarily low-grade, low-growth rate, indolent, and they're very slow. And she's sort of shocked that this doctor is doing something really fast while he's still got tests out for testing. Is that what it sounds like to you?
Yes.
All right. Do you agree with this? Her oncologist comes to her rural community from a large cancer center, and he said that after the gene testing, if his ideas change, he can change treatment, and if there are clinical trials that make sense, he could do that as well. He is very worried about her downhill course, obviously. So what she's saying here is, I went to Dr. Google. I learned that neuroendocrine tumors are supposed to be slow, and my sister's going downhill rapidly, and this doctor's jumping in there and kicking ass and taking names. What's going on? Is that what that question says? That's a country way of asking a question, right? All right, put up the first one. So this is we have not talked about neuroendocrine tumors here. I looked back, and it's about 1.5 years ago, after COVID started, we had a neuroendocrine tumor of the appendix taken out in a routine appendectomy, and they were doing nothing. They were observing it, and which was the right thing to do. Okay, so we'll start off. What are neuroendocrine tumors? You got that up there? Everybody can read it once. Pull it down. So we are now, put up the next one. We're now talking about a liver biopsy in a highly rapid progressing neuroendocrine tumor. This becomes, you got the next one up, right? This is now a neuroendocrine tumors of unknown primary site. You got that, Lonnie? Pull it off of there. Okay, now, I'm not going to ask BJ. See, I can embarrass Lonnie without you having to look funny. When we talk, Lonnie, what does CUP mean? You remember what CUP means? Cancer of unknown primary. Remember, we talk about that all the time. They stick a needle in there. I said it looks under the microscope like you could say, oh, this looks like breast cancer, this looks like lung cancer. Sometimes it just says it's cancer, and you can't tell where it started, but you know it didn't start in the liver, right, or you know it didn't start in the lung. So what do we call it? Cancer of unknown primary. All right, put up the next one. So, adult neoplasms of unknown primary site that are neuroendocrine, so that's cancer of unknown primary. This woman's right. Indolent biology. Look at all of these kinds of cancers that are slow growing primarily of the GI tract on that side, but aggressive biology, small cell, like lung, high grade, poorly differentiated, small and large cell. Pull that down now. So now we're going to talk about the difference between small cell and large cell. Now, where do we say large cell and small cell every week? What kind of lung cancer? Non-small cell lung cancer. We talk about that all the time. 4 times we talk about non-small cell lung cancer to every 1 time we talk about small cell lung cancer, because that's about the distribution. And small cell lung cancer, remember that word goes back 40 years, is now called small cell lung cancer with neuroendocrine features. And we don't say that on here most of the time because it has nothing to do with lung cancer. But in this case, it's crucial that it has neuroendocrine features, because that makes it quite likely that it came from lung. Now, put the next one up. We're not going to make everybody read everything, but if you read on the left-hand side, 16 out of every 100 people with lung cancer have neuroendocrine tumors. So that's really the small cell lung cancer. Pull that, wait, one minute. You see where it says small cell down here? Then it says large cell neuroendocrine down there, and then it says carcinoid down there. Well, small cell lung cancer is 98% of that 16. So pull that down. I said we'd talk about non-small cell lung cancer 4 to 1. That would be 20% of 100. That's 16. That's darn close. So that tells you why these questions come in. 1 out of 5 is small cell lung cancer, and 4 out of 5 are non-small cell lung cancer. All right, put up the next one, because what they said in this question is very poorly differentiated. Put up the next one. You get down here to this poorly differentiated here, and you get it is immediately, it tells you the most common is lung cancer, and that it's rapidly dividing. That's over here on the right hand side. Pull it down. So what we used to say about this is small cell lung cancer is like acute leukemia. And when I was in medical school, remember I was in medical school 60 years ago, we would tell patients this is wildfire cancer. That was a common cause, remember something growing like wildfire? You don't like that? All right.
Yes.
So we're gonna be brief with this one. Throw that one back up again. This is the, what's that? It's an algorithm, right?
Yes.
But it's an algorithm with a lung on one side. So
yes.
This basically how you go through it if it's lung to get to small cell and to get to the neuroendocrine at the bottom. Now we're going to put up a survival curve for BKP, but only briefly. What can you say about that survival curve? You don't survive, right?
I didn't want to say it.
Okay, we'll just look at it. So your survival curves do like this, right?
Yeah, I was getting ready to say.
That falls like a rocket, and then it's flat at the bottom. It's flat at the bottom at 2%.
That's a non-survival curve.
That's a non-survival curve.
It really is.
So
actually, that is the very first time that you brought one of those that I can remember.
Yeah, that's right. That's why. Okay, look me square in the eyeball. The average survival of small cell cancer from the time of diagnosis to the time of death without treatment is 6 weeks. If anybody lives 6 months, they are in a pretty good group, and very few live 1 year. Now, I've said here repeatedly when we're talking about it, we generally now get about 80% of people to a year. We get about 30 to 50% to 2 years, and then there's a long tail of 20 or 25% that's a flat part of the survival curve that survive if we kick ass and take names, which is what this doctor's doing. Now put this next one up here. This is a survival curve in a different way done for BKP, and the left-hand dark side is the treated side, and the right side is the untreated side, and this is a yearly thing. So when you get to 1 year, 1 out of 5 patients with small cell lung cancer make it a year without therapy. Now this is before the most modern one. As I said, we're getting now about 75% of them out to a year, and then this black part then comes, which is the treated part, does much better. Are you with me now?
Yes.
All right. So how far are we along? Okay, we're gonna stop here. I got 3 more slides. I'm not going to show them, but the way to treat this disease is with the 3-drug combination of drugs. That is, in essence, kicking ass and taking names, and that 3-drug regimen was developed for small cell lung cancer. And I will tell you that you don't ask this question here, but everything that this doctor's doing makes sense. Now I want you to listen to this, BKP, because you just got back from Florida, and you had a very sick mother that wasn't 1,000 miles away, but she was a long way away.
800 and some.
800 and something. So what did I tell you to do? I told you to go there, right?
Yes.
Go there. Yes. Talk to the doctor. Go there. Make sure you understand.
Yes.
Go back. Once she starts getting treated to your mother, keep going back and asking questions and supporting your mother. So I'm going to tell you, sister, you get in your car on your airplane and you go the 1,000 miles and you go visit your very sick sister, because it's entirely likely that she will not do well. It is also entirely likely that she might, but she'll be going through aggressive therapy just like RCHOP for your mother. And what did I tell you to do? Keep going back. Keep going back. Ask questions. Support mother. So, sister, the doctors are taking good care of your mother. Get off of Dr. Google. Get in your car and go visit your sister.
And I want to say this, and I'm glad you brought that up, because and Dr. Whaley knows at any time we're discussing these and talking about these questions that are surrounding cancer, families, what family goes through, he knows very clearly he could bring up anything where my mom and what our family went through with our mother. Is she's doing fine.
We talked about it on the air.
Absolutely.
It's not a secret.
but I think it's 850 miles from here. You're right. I do know people get in a position like maybe they can't go. I know it's a struggle. I know what it's like on a family to do that. But what I don't hear in this question, and what would be important to me, is who's going to the doctor with your sister, who is in the room with your sister. That is something I'd like to know. You know what I'm saying? So that's why you're right.
Yeah.
Go and be there and listen to.
Well, she's very concerned about her sister.
Yes, she is.
So
yes.
we know that. And she's trying.
Understandably so.
Everything about this question, it tells me she's worried about her sister. Everything about this question tells me that the sister's getting appropriate care. But the one part that I want to emphasize is, even with appropriate care, by showing those survival curves with good care, she's going to be taking a lot of treatment. It's going to be hard on her, and she's going to need a support system.
Right.
And you go visit your sister because it's important.
All right, so do you want to go with that, or you want me to show you my questions?
Well, I'm going to go with this for just a minute.
Okay,
I'm going to
because
go with
I
this
have
for-
two.
I'm going with this for just a minute because there's two things I think people need to know. The first one is that I just want you to read that right there because I know you read it.
Insurer told to pay $5.2 million to woman who caught STD in a car. Yes, I did read that. How did you know I read that? Yes.
All right.
Insurance company, she said she
Geico.
she got a sexually transmitted disease in a car, and the insurance company is. Oh, go ahead. I'm just caught.
It's
that I read that
It's
article.
incredulous that, I mean, my mother's was a lawyer. My father was a lawyer. All three of my brothers are lawyers. One's a federal judge. They all worship the law, and I cannot imagine any member of my family bringing a lawsuit against Geico with the little gecko on the television because some woman had unprotected sex with a rake and a rambling man who knew that he had HPV, and he transmitted HPV to her. Now, HPV is not a serious disease, not like HIV. And how to get 5.2 million. Do you know how many people in our age group have HPV? 92% of us have HPV. 92%. Now, if we got that HPV in the back of a Rolls Royce with some guy, would we all going to be suing the guy? I mean, it just makes no sense to me. Now, the second one is, and I don't know if you're going to talk about monkeypox or not.
No.
Okay, but monkeypox, I've getting people asking me about monkeypox every blinking day. And monkeypox is quite likely to become endemic in Western Europe and in this country. I think we now have 12 or 15 cases of monkeypox in the U.S. Very carefully, when they talk about monkeypox, they say it occurs primarily, these cases have occurred in the United States and in Western Europe, all of them linked to two big parties in Switzerland, and all of them occurring in men who have sex with men. And yet their bodies rub together. So it's not going to be long before one of them has sex with a woman, and then it's going to be there. So there's going to be a low-grade monkeypox around here for a long time. This is not a big deal, but it might reinstitute smallpox.
It's not a big deal until you get monkeypox in the back seat of a car.
Yeah, all right.
And you call the insurance company.
Well, it goes away in 4.
I had to say
it goes away in 4 to 6 weeks, and it's not the serious disease that smallpox was, but it's another place where human behavior and lack of restraint is causing an issue.
Are you trying to filibuster my question?
No, I'm now finished. Go.
Okay.
All right.
Because I know we got to get... Now, this is turnabout is fair play. Read that.
First time this has happened, doctors are left shocked after a clinical trial for cancer drug cures the disease in every participant. Now, I've seen that about 5 times in the last 48 hours, and that's a monoclonal antibody, and
it's treating colorectal. Is that it?
Colorectal.
Colorectal cancer. That's what it's.
Okay,
right.
now that's, you just take the idea of the Keytruda drug, Jimmy Carter's drug for cancer. Remember now, it first started out with one cancer. It's basically the broad spectrum antibiotic of cancer, and you can use it in many, many, many cancers. What happens there is that you have got 18 people who have advanced cancer and who have exhausted usual customary therapies, who have a marker that says this drug, which has not been approved in colorectal cancer, might work, and so they're part of a clinical trial. And look at this is Blue Ridge. We got us a bird on our
Good morning. How are you?
in our studio. Good morning. My bird feeder's on the other side of the building there.
You could stay.
You can stay. So basically, the next 18 patients, 6 might respond. So the point is, this is what we call in medicine anecdotal, small series, uncontrolled, and the data that they will say it's interesting, it's compelling, it's unconfirmed, and it suggests that that clinical trials should be instituted where that drug is used under good, rigid experimental circumstances and used in thousands of patients, because colorectal cancer is so common, it won't take long to get a good, statistically valid study of that drug.
All right, read this one, and then you got to go to work.
All right. New vaccine could prevent pancreatic cancer, one of the deadliest kinds, from returning. Currently, only a quarter of patients survive 1 year after diagnosis. Okay, we have discussed vaccine therapy here before for malignant melanoma, and we've discussed vaccine therapy here before for kidney cancer. Vaccine therapy is, again, a budding, highly technical treatment where the protein of the cancer is used to create a vaccine against the cancer. It's really done now. We have what's called CAR T therapy, where they take the patient's lymphocytes out. Remember, we talked about this. They're sent off to Canada, they used to be sent off to Sweden, now they can be sent off to Boston, along with a piece of their cancer. And then it goes up there, and those lymphocytes make antibodies against that cancer. Then those antibodies are brought back and given in the vein to the patient with the cancer, and it's curing 100%, 90% of cancers that could not previously be cured. So that is the cancers making the antibody in a lab. The vaccine is the same concept, except now you're taking the protein, you're putting it with some virus so that you make that virus goes into the body. Let's just say you hook that to the COVID, vaccine. You hooked a pancreatic cancer protein, slice of protein to the COVID virus, and then you made that vaccine, whack it in there, and it would make you immune to the COVID and to the pancreatic cancer at the same time. So that is a very encouraging, unsupported report of a very important biological concept that's being carefully evaluated in many types of cancer. Pancreatic cancer is so devastating, like that small cell cancer we saw earlier, that anything that you can make that will have you have your own body fight it off, which is what that is encouraging.
Is it time for you to get to work?
It's time to get to work.
Hey, you know what? I really like this jacket.
It's nice, isn't it?
Yeah, it's a nice jacket.
Even for Kurt Fraser, who is huge, it has trouble getting around you, though.
Oh,
with that,
wow.
We'll go to break.
No, Georgia
Northside
Cancer Specialist,
Center.
Northside Hospital Cancer Institute. We'll take a short break, and we'll be back with the All-Star panel.